Hello, everyone. In keeping with today's theme of mental health and well-being, I'd like to share some results with you from a big data study. So I'm Sarah Rogers, and I'm the theme lead for the Care and Health Informatics theme in the North West Coast ARC. So we use data that are routinely recorded by the GP from patients, and we use them in this study for our secondary research purpose. And using these health data that are recorded several times each year allowed us to bring in a temporal element that moves us towards causality, which is a more robust study design that is liked by policymakers and the Department of Health and Social Care. So we asked, is exposure to green and blue space associated with preventing people from developing common mental health disorders? And the word that I've written in the title here, subsequent, is important because we set up the study to make sure that the timings of exposure to their environment was recorded before the GP recorded a diagnosis of symptoms of anxiety or depression. So how are we measuring green and blue spaces? Well, my colleagues created a few different measures. We first had an ambient exposure to greenness very close to home. So this was the amount of vegetation seen from the front door. And we collected this from satellite imagery. This is an important and appropriate measure because we don't need people to go into the space, the green space, or the park, for instance, to benefit their mental health. They just have to see it from their home and close to home to potentially feel restored. So then we used Ordnance Survey map data and counted both green and blue spaces within a distance of 1,600 metres or a mile. We thought we'd see if we could model how people might go to their local parks and ponds more if they lived closer to them. Just to impress on you that this really is a big data study, we had a decade of following up people's healthcare use. And because this was for more than 2 million adults, this resulted in 19 million person years of follow-up. Our results showed that there were fewer people reporting anxiety and depression to their GP if they live in greener areas. We saw that being able to view green space close to home was associated with a 20% lower odds of developing anxiety and depression. So that's a reduction of a fifth, with fewer people going on to develop a CMD. Second, we showed that more accessible green or blue space in the larger 1 mile distance was associated with 7% reduced odds of anxiety and depression. Finally, for this analysis, looking at differences between people and subsequent mental health, we saw that there's a potential echogenic benefit to mental health from living in a place that has more potential access to green or blue spaces. There was a larger protective effect in the more disadvantaged areas. So for people in areas that generally had fewer resources overall, there was more benefit from their available parks, lakes, and outdoor nature trails. This study had several strengths, and it's a step forward because first, we most definitely have the exposure first and then the health event. And this often isn't the case because the amount of green or blue spaces that people experience at different times, their exposure, is often not recorded at the right time. We could do this because we could look anonymously at the individuals and update their green and blue exposure when they moved home, thanks to the household linkage mechanism. Second, we included large numbers of people, so there was no selection bias in whose data we had. We had nearly everyone's data for all adults in Wales, 2.3 million. We had the environmental data at the household level rather than at small areas, so reducing something called ecological fallacy. And this is really important over the 10-year follow-up time in our study, because if an area is improved, then we'd like to know that we're measuring the same people and not just the new people who have moved in because it's been regenerated and the original people have been displaced. We had some limitations too. We still have differences between people, so we cannot rule out self-selection. In this larger study with millions of homes and people, we did not have any behaviour, activity or GPS data, which are really useful. We used records of people seeking help from their GP, and this is much better than only having hospital admissions, but we didn't have well-being measures. So these data could be considered rather a blunt outcome measure. And I think this is especially true because we know that another 30% of people live in the community with anxiety and depression, but don't seek help from their GP. This study was set in Wales, but we've since been commissioned as part of a new large project called Groundswell to work with Liverpool City Council using data held in Cheshire and Mersey to characterise the access to green and blue spaces for the wider city region from Wirral through Knowsley and Sefton. So we'll be looking at not only mental health, but setting up our data to look at conditions that might be impacted longer into the future, like cardiovascular conditions. We're currently working with Wirral Council and the Liverpool City region to make sure that new parks and transport are designed with all of our residents' needs in mind. And to that end, we've got several public advisors from the Arc Northwest Coast who are helping us with this. So we want to use the big data to evaluate, but also collect survey data to add well-being and behaviour data that aren't routinely recorded. Bringing this full circle back to where Pete began. This means that it's important to have the mechanism to create household linkages so we can add to each home the distance to the nearest park, for example, so that we can evaluate the changes and make sure they are improving health and reducing health inequity. Thank you very much for listening today, and the CHI team and myself will be very happy to answer any questions.